Srinivas Nayak, also known as S.P. Nayak, was born on July 12, 1994 in Kaloni Thanda, a Lombardy community village near Melaguda, close to J.P. Dargah, a reserved Sufi shrine in Farooq Nagar Mandal, Rangareddy district, Telangana, India. A trailblazer in academics and research, Dr. Nayak is qualified QCHP Ministry of Health Qatar pharmacist and a two-time GPAT qualifier professor in India. He has published over 60 research papers in prestigious national and international journals, showcasing his dedication to advancing pharmaceutical science. For his research and contributions to healthcare, he has been honored by several international organizations, including WHO, UNICEF. He has been honored with numerous awards in India. Beyond his professional achievements, Dr. Nayak is ideologically a humanist, atheist, and rationalist, deeply inspired by the principle of Baba Saheb Ambedkar, Jyotiba Phule, and Periyakar E.V. Ramasamy. He is recognized for his progressive outlook and commitment to social reform. An active participant in Bharatiya Vidyarthi Morcha and SSF during his student years, he has now shifted his focus to scientific research, emphasizing evidence based practices. Dr. Nayak's inspiring journey is a testament to perseverance and self determination. After his father's after his father left their family, his mother became the pillar of strength who shaped his values and determination with lots of struggles. His education began at Netco High School, a transformative institution for underprivileged communities in the region. He stood out as a bright and hardworking student known for his keen interest in learning, particularly in science, biology, and literature. His academic excellence earned him the title of Best Outgoing Student for the 2010-2011 batch. Continuing his education at Netco Higher Secondary School, Dr. Nayak emerged as the town topper of Srinagar in intermediate board exams, further solidifying his reputation as a dedicated scholar. Dr. Nayak holds a doctorate in pharmacy from JNTU, Antapur, Andhra Pradesh, and a Master of Psychology from Dr. B.R. Ambedkar Open University. His multidisciplinary approach reflects his passion for integrating science and psychology to address complex healthcare challenges. Dr. Nayak began his academic career as an assistant professor at Sultan Ulm College of Pharmacy, Hyderabad. He later joined Paro University, Gujarat, where he currently serves as assistant professor at Paro Institute of Pharmacy and Research, clinical preceptor at SSG Government Hospital, Vadodara, research scholar in Department of Nephrology. His research focuses on bridging the gap between clinical practices and pharmaceutical advancement, contributing significantly to healthcare and patient outcomes. Dr. Nayak's work and principle are deeply influenced by his admiration for progressive thinkers like Ambedkar, Phule, and Perikar. He envisioned a society driven by scientific temper and equality, dedicating his efforts to both academic excellence and social reform. Through his unwavering commitment to education, research, and community service, Dr. S.P. Srinivas Nayak exemplifies resilience, intellect, and the power of transformative action. Please join me in welcoming Dr. S.P. Srinivas Nayak. Sir, the stage is all yours.
Okay, thank you. Am I audible?
Yes, sir, you are audible.
Okay. Thank you for the wonderful introduction. Shall I share my screen?
Yes, sir.
I think my screen is visible to everybody. Yes.
Yes, sir.
Yes, yes, it's visible.
Okay, so let's begin our session. Firstly, I would like to thank RX Doctors team, entire team who is making a lot of efforts to create certain what we can say opportunities for PharmD students and uniting everybody here, and they are giving opportunity to share their thoughts. So I am very glad to be the part of this session. And one thing I would like to say is already in the previous session, I think Dr. Akhil, he has covered majority of concepts. We both were given with the same topic, so I don't have anything new to discuss. But anyways, I'll try to uh, convey my own concepts with certain clinical cases. Okay. So I think my audio is okay to you all. Shall I begin?
Yes, sir. Your audio is good.
Okay, okay, fine. If my screen is not visible or if the slides are not changing, please let me know. Because in the previous session, sir was continuing and only single screen was visible. I was about to say, but I was not sure whether he is having some technical issue. Anyways, so before understanding our concepts, let me give you some brief things. We all know that we should try to know some terms. We have neonates, right? Neonates. Neonates are the populations or the people who are from the birth to the 28 days. They are considered as neonates. Or in simple terms, we can say the patients who are of 1 month age. If they are with 1 month age, they are called neonates. And we have pediatric department, right? In hospitals, we have pediatric department. So pediatric department usually they will be dealing with the cases starting from the neonates who is from the birth to 18 years, or you can simply say till adolescent, okay, till we are adult. So all those patients who are having any diseases or disorders, whatever they get, they will be treated by pediatricians, okay. And in some cases general department, general physicians also can do all this activities. And the next very important concept is geriatrics, okay, because I am dealing with the geriatric population. So geriatrics are the patients who are above 65, the age whose age is above 65, they are considered as geriatric patients. So you should know what is a neonate, what is a pediatric department, and what is a geriatric department. So in geriatric department, we will find all the elder populations, all old people, grandma and grandpa people will be seen in geriatric patient. And being a clinical pharmacist, we should know many clinical points about geriatric patients. And we should see in geriatrics, we have a lot of pharmacokinetic and pharmacodynamic changes in the patients. And we have some challenges during treating when patients were treated with certain drugs. Okay, so before starting with the physiological changes and all, let me tell you the statistics of geriatric population, particularly in India. See, if you see the percentage of geriatric patient in 2021, our percentage was around 10. Okay, so in 2021, I guess our population was approximately 130 crore. And in 130 crore, if we see the 10% of geriatric patients above 60 years were 10%, that means approximately 13 crore people were present in 2021, and in 2020, in 2036 we are estimating that it will reach to above 15%. So by 2036, if population goes to 200 crore, so just imagine, in this 200 crore, if geriatric patients are 15%, that means 30 crore people, 30 crore will be geriatric patients only by 2036. Okay. So, and in the same, if we can see 80 years patients, it will be approximately the population. I'm sorry. Am I audible? Hello.
Yes, sir.
Yes, sir, you're audible.
Yes. In between, if I get any call, I may disconnect. But anyways, I have some network issues. If anything is wrong, let me know. Okay, fine.
Yes, sir.
So these are the statistics already. I think Dr. Nayak has explained the
Sir, you're not audible if you're saying something. You're muted actually. Sir, you're not audible.
audible now.
Yes, sir, you're audible now.
Yeah. I just got an important call. So, anyways, chalo. Is my screen visible? Is it changing?
Yes, sir. Yeah.
Okay. Fine. Sorry for disturbance. Anyway, see, in India, see, by 2050, as I was telling, by 2050, 1 in 5 are going to be the geriatric patients in India. So just try to imagine, India is growing, not in terms of economy or not in terms of other things. India is growing in age also. Okay, that this thing we have to understand. Okay, in terms of economy and all, that is also fine. India is doing very well, and we should be proud that India is one of the top 5 GDP nations in the world. Okay, chalo, let's actually begin our session. So, in geriatric population, we should have some objectives. Why is it necessary to understand about geriatrics in hospital? Okay, so the first objective is to recognize the physiological changes that happens in geriatric patient. If any patient is above 60 or 65, they will not have same physiological changes in the adults as well as in pediatric. Okay, physiological changes are different in pedia, and they are different in adults, and they are different in geriatric patients. So we should know what physiological changes are seen in geriatric patient, and that how they affect to the drug therapy, that we will try to find out, and that is the main objective of our session. And next we'll try to identify the high risk drugs. Not all drugs are potentially harmful in geriatrics. There are some drugs, and in those drugs you have to remember the narrow therapeutic drugs. Okay, always whenever I take lecture, I always talk about narrow therapeutic drugs. In that, we have anticoagulants like warfarin and cardiac glycosides like digoxin, and anti-arrhythmic drugs, some anti-cancer drugs, and we have immunosuppressants. And in antibiotics, we have a very important drug called vancomycin. and some drugs like aminoglycosides, very commonly used in hospitals. Okay, so all those drugs are considered as narrow therapeutic drugs. So when these narrow therapeutic drugs are prescribed in the geriatric patients, clinical pharmacist has to focus. Our main objective is to analyze the prescription in hospital, and we have to reduce the medication errors, right? That is the main point, right? So in geriatric patients, first thing what we have to do, we should try to identify the physiological changes. Second, we should identify the high risk drugs. And next objective is to apply the practical strategies to optimize medication or to reduce the medication errors. Like we have deprescribing methods like removing the drugs or adjusting the doses. If any patient is having a drug toxicity, we should try to decrease the dose, okay, by calculating the exact dose. And monitoring, like we have therapeutic drug monitoring. If slight increase in the narrow therapeutic drug is seen, they will cause severe toxicities, and organ failure can be seen, like nephrotoxicity, cardiotoxicity, and sometimes neurotoxicity as well. And in many patients, geriatric patients, they'll have deafness, which is called ototoxicity. These are very simple things. Usually the nurses and the physicians will not take care actually. So clinical pharmacist has to focus on all these things. Okay, and the fourth objective is to work through real cases. Okay, so I'll try to illustrate some clinical cases for decision making. So I bought some cases also, we'll try to solve those cases. Okay, so yeah, after learning objectives, we'll try to find the pharmacokinetics. Okay, changes in the pharmacokinetics, as Dr. Akil sir was already mentioning about pharmacokinetic changes. Always remember one thing: when our age increases, okay, gradually the blood perfusion to certain organs will decrease, and in the same way blood perfusion to kidneys also decrease, and it will cause decrease in the GFR. Very important point. As age increases, gradually our GFR will decrease. Okay, this is important point. Actually, when we are in adult age, our GFR will be approximately 100 ml. Okay, and gradually if we increase our age, gradually our GFR will fall to 90, 80, 75, like that. Okay, and second thing is hepatic metabolism also decreases. As I told, blood perfusion to certain organs will decrease. Blood perfusion to liver also decreases, and in liver we have some enzymes called cytochrome P450 enzymes, which are very important in metabolizing the drugs. The enzymes which will detoxify all the toxic substances in our body. All the drugs are considered, okay, toxic to our body if they are not eliminated. If the drugs are not eliminated out, they are considered as toxic. Okay, so the cytochrome P450 enzymes will decrease, and blood perfusion also decreases. That's why the hepatic metabolism decreases in geriatric patients. And the third point is, in geriatric patients, the volume of distribution is increased. This point is very important. You know, you should know about volume of distribution. So I think all pharmacokinetic points we will discuss later, because here if I keep explaining all these things, it will take a lot of time, because I have to discuss the clinical cases. Anyways, volume of distribution is nothing but it is the amount of blood which is distributed in the tissues by the plasma serum concentration. All, I think all PharmD graduates knows these concepts. See, one thing here I would like to add: if the drugs protein binding is high, if protein binding capacity of certain drugs is high, their volume of distribution decreases. That thing we have to remember here. Some drugs I would like to tell examples. We have sulfonyl ureas, we have sulfonamides, okay, some antibiotics, and digoxin, phenytoin. All these drugs, uh, protein binding capacity is high. If any drugs protein binding capacity is high, they will have decreased volume of distribution. And if the drugs penetration property is high in the tissues, that means their volume of distribution is high. And if we talk about the lipophilicity, the drugs whose lipophilic nature is high, if the drugs are lipophilic in nature, their volume of distribution is also very high. Okay, lipophilicity and protein binding capacity is quite different, opposite in volume of distribution, that you have to remember. Okay, anyways, here it is already mentioned. Okay, for lipophilic drugs, volume of distribution is very high. And the other point we have to remember is a pharmacodynamic activity of certain drugs increases, as Akhil sir was already mentioning. Some CNS drugs and anticoagulants and antipsychiatric, some psychiatric drugs, they will have more sensitivity. And here, if we go with warfarin, the warfarin activity will be high in geriatric patients. Okay, because their sensitivity is high. And in geriatric patients, already we know patient will have many comorbid conditions. Patient will be suffering with asthma, they will be suffering with anemia, they will be suffering with arthritis, they will be suffering with some hormonal replacement therapies, but hormone deficiencies in female patients. Okay, they will have diabetes, hypertension, very common. Diabetes and hypertension is very common. So they will have many diseases, and because of all these multi comorbid conditions, they will be taking multiple drugs. So even this becomes the risk to optimize the therapies in geriatric patients. Okay, and along with all this, they will have higher risk of developing ADRs and adverse drug events. Okay, so for this, it is very important for us to focus on evaluating the prescription. And sometimes non-adherence. See, geriatric patients, what they'll have, they won't remember what drugs they have to take. If the physician prescribes certain drugs for 3 times a day, they will forget. They won't take drugs 3 times. They'll take only once. So that will cause non-adherence. Okay, that may be due to lack of interest or due to cognitive impairment. Alzheimer's is commonly seen in geriatric patients, and some social factors also. Some older populations, what they feel, if they take allopathy drugs, they think that they'll get a lot of adverse effects and they don't take. This is a myth actually. All geriatric patients, particularly in India, what they feel, if they take allopathy drugs, they feel that they will destroy their body and they'll cause a lot of adverse effects. And they believe in allopathy, they will believe in Ayurveda and homeopathy other than allopathy drugs. Okay, so this is social factor actually in India. Usually it is a myth and it is a superstition. So we have to counsel the patient regarding all the allopathy drugs and their importance in geriatric patients. Okay. Now, as I was telling, there are some pharmacokinetic and pharmacodynamic changes. So particularly if you see in the absorption, the gastric acid secretion in geriatric patients are very low. I mean, they are quite lesser when compared with the adults. So some acidic drugs are not easily absorbed from the small intestines because they need acidic pH. And particularly if you see the iron supplement, okay, usually in females, if they are suffering with iron deficiency anemia, iron tablets and folic acid, irons, we usually we call ferrous sulfate. Okay, 360 mg, 400 mg tablets are very commonly used. So in geriatric patients, when iron tablets are given, due to decreased gastric acid secretion, they will not be absorbed properly from the GI tract. Always you have to remember, okay, usually the iron is absorbed from the duodenum. You should remember this. And the absorption of iron is potentiated due to acidic pH. Iron absorption, for iron absorption, we need acidic pH. That's why when a patient is taking iron supplement, always advise them to take with ascorbic acid or advise them to take with empty stomach, not with food or not with calcium supplements or doxycycline or anything. Particularly iron supplements are not taken along with antacids. Okay, along with antacids, they should never be taken. And usually most geriatric patients, they will be on different drugs. They will be taking antibiotics, they will be taking NSAIDs, they will be taking a lot of drugs, no. So along with NSAIDs, usually physician, what they do, they'll prescribe proton pump inhibitor. Okay, pantoprazole, omeprazole are commonly used drugs. So when they are taking these drugs, iron will not be absorbed. So that, like that, things we have to be very careful. and they will have slowed GI motility. Usually in geriatric patients, GI motility is very less. Okay, with that they will cause constipation. They'll have constipation. Constipation is very common physiological change that is seen in geriatric patients, and if we see such symptom in the patients, always don't advise anticholinergic drug. Anticholinergic drugs, any drug should not be advised, or if they are given in emergency cases, we should monitor. And along with that, opioids. Okay, opioids should not be advised if patient is having constipation. And along with that, we have some drugs. Can anyone tell me some other drugs which will cause constipation? Drugs which will cause constipation? Anybody from the class? Drugs which causes constipation. Already geriatric patients will have constipation. Not everybody, but they are having probability of GI reduced GI motility, so they'll have constipation. Any drug, any potentially common constipating drug. Are you all following me? Am I audible to you?
Might
Yes,
be
sir, you're
calcium
audible.
channel blockers.
Calcium channel blockers. How calcium channel blockers will cause constipation? Theoretically, it
NSAID,
cause
sir.
NSAIDs will cause constipation.
Yes, sir.
NSAIDs and calcium channel. Where did you study all this? I have not studied, and I have not seen. NSAIDs will cause constipation. Any logic or mechanism behind that? Anyways, we will discuss all these things in question and answer
Aluminum
session. But
hydroxide.
aluminum hydroxide will cause constipation. Okay, that may cause constipation. Okay. See, all anticholinergic drugs, as I told, opioids, and we have antihistamines also. Antihistamines will cause constipation. Okay, and the drugs which will aggravate the anticholinergic activity, atropine and atropine analogs, all atropine analogs will cause constipation. Okay. Anyways, we will discuss all these later. So the first thing about the GA tract in the absorption, due to slowed gastric motility, some drugs absorption may be increased. Okay, and gastric acid secretion will be decreased. That is one thing. And in distribution, if we see, the fat distribution is very high in geriatric patients, and they'll have lean mass. Okay, and albumin also decreases. Albumin here, this is very important. We have see serum proteins, we call plasma proteins, not serum, plasma proteins we call. In plasma proteins we have albumin and globulin. These two are the carrier proteins which are very important for transportation of drugs. Okay, when the drug is absorbed from the small intestine, they will be taken to the liver by the hepatic portal vein, and from the liver it should be transported to all parts of the body, right? So that transportation is done by all these plasma proteins, albumins and globulins. And in geriatric patients, which are in that patients, due to lack of liver activity and due to lack of production of these albumins and globulins, drug distribution will decrease. Drug distribution will not be seen, and the free form of the drug can be seen in geriatric patients. So we have to be very careful. There are some drugs like just now I told, sulfonamides and sulfonylurea. Sulfonamides and sulfonylureas, these both the drugs are having high protein binding capacity, and in the patient albumin levels are less. When these both the drugs are given, sulfonamides will go and it will replace the sulfonylurea, and sulfonylurea activity increases and it will cause severe hypoglycemia. Very important point. We will try to discuss all this in cases. Okay, remember this. In distribution, albumin concentration will decrease in the body, and with that distribution of drugs can't be seen. And next is metabolism. As I was telling, due to reduced hepatic blood perfusion and due to reduced amount of cytochrome P450 enzymes, and the drugs will not be metabolized properly, and with that it will decrease the hepatic clearance. That is important point. In metabolism, drug metabolism will not be as it is seen in adult patients. And finally, if we see the excretion, in excretion, as I was telling, GFR is decreased and elimination is not appropriate. I mean, elimination is very slow. Okay. Because of that, we have to monitor the drugs, and drug administration frequency has to be increased. That points also we will try to discuss. And in pharmacodynamics, drug sensitivity will increase and they may cause toxicities in some cases, especially the CNS drugs and some anticholinergic drugs and anticoagulants as well. Okay. Now, in geriatric patients, we will find some common prescribing problems. One is polypharmacy, because due to many comorbid disease conditions, patient will be taking more than 5 drugs. It is very common in hospital in geriatric patients. Okay. And inappropriate medications. Okay. uh, when drugs are prescribed to the geriatric patients, appropriate drugs will not be given. Okay. Already patient is at higher risk of nephrotoxicity and they will be prescribed with high nephrotoxic drugs, NSAIDs. Okay. So in that cases, we have to be very careful. And some anticholinergic drugs, long acting benzodiazepines, which will cause sedation, and opiates, as I was telling, and some antipsychotic drugs. These drugs, changing these drugs are very important. Okay. For the pharmacist. And dosing is not adjusted as per the GFR and as per the patient's requirement. Okay. And sometimes unclear therapeutic goals. Okay. This one, and some poor reconciliation is also one of the problem. All these are common prescribing problems that can be seen in geriatric patients. And along with that, we have some one is non-adherence. Sometimes the patients will forget the drugs. The patients will not, they will be not in a position to take the drug. Some of them are having a lot of problems. So geriatric patients has many prescribing problems. Among them, these are the important one. Okay. Now we have some tools. Okay. In hospital, we should try to use these tools and try to monitor, optimize the cases. Akhil sir was already he was explaining about this criteria. I think there is a Beers criteria, stop and stop criteria we have. Let me try to show you practically. See, we have med stopper, one resources, freely available resources. See, we have drug related resources like WebMed, Medscape, and Clinirex, and so many resources we have, right? So like that, for geriatric patients, we have some resources for de-prescribing. Okay. So let me show you. Once I'll go to the Google and I'll try to type the this. I think my screen is visible to you all, right? Already these concepts were explained by Akhil sir. That's why I'm just. Okay. See, I'm just typing. Are you all following me? Please unmute your mic and let me know.
Yes, sir.
Can you all see my screen?
Yes, sir. Google screen is visible.
Okay. So I typed mid stopper here and I'm going to the website. And here what we have to do is we have to type the drugs what geriatric patients are taking. For example, I'll type here digoxin. Okay. And 1 second, please. 1 second, I'll come back. Okay. Yeah. Where were we? Yes. So see, in mid stopper, what we have to do, we have to type the drugs which are given to the geriatric patients, and what we have to do, we should select the condition. For example, if the patient is suffering with heart failure, and I'll try to add it here. So here we have to check if the drug is showing potentially harmful adverse effects. What we have to do, we have to remove those drugs from the prescription. So like this, we can add lot of drugs here. Along with the digoxin, I'll add warfarin also. Actually, it is a software which will say that if the patient is taking multiple drugs which are harmful. So for warfarin, if the patient is having arrhythmia, or if patient is having valve replacement therapies or anything for that, or if patient is having deep vein thrombosis, for that cases, see here I added warfarin and digoxin, and here for digoxin it is showing red alert. For digoxin it is saying to be careful. Here it is saying worsening of symptoms, increase in the heart rate. So like this, multiple drugs you can add, and based on this you can see that if the drug has to be removed from the prescription or not. Okay, so multiple things you can do. Actually, this is a resource actually for us for okay, so in Beer's criteria, this is one of the resource we have made stopper, okay, for de-prescribing certain drugs. If the drug is showing any potential harmful side effect, so we can remove those drugs, and alternatively we can go with the some other drugs which are quite safer. Okay, so I think you understood how to use this med stopper. Actually, it is very simple. Okay, already Akhil sir has explained about all these concepts. Next is we have practical 6-step algorithm while treating the geriatric patients. Okay, while treating the geriatric patients, we should follow this algorithm. First, what we should do? First, gather the complete medical list. The first thing is we have to check the different drugs what are given in the prescription. Okay, including, I think someone is talking. Okay, including OTC drugs and herbal drugs. See, majority of older populations, what they do, they will take some allopathy drugs. Along with the drugs, they will be taking some herbal alternative drugs also. That also we have to write in the prescription. So first thing what we have to do, we have to gather the complete medicine list. Next, we should clarify the goals. What goals we have? For example, if patient is suffering with hypertension and diabetes, we have to monitor both diabetes and hypertension, and we should manage them. That is the main goal. Okay. If they are not managed properly, that means your goal is inappropriate. And the third thing is we have to go with the each drug. Check the each drug. Their indication is properly done or not. If they are causing any benefit or harm, or their doses are properly mentioned or not, their frequencies and everything we have to check. Okay, this is the third step in our 6-step algorithm. And the fourth one, we have to check the patient's renal and hepatic function. And if any drug is showing any interaction between this drug and disease, we should be very careful. Okay, there are some drug interactions like aminoglycosides. If we see the example, they are having interaction with the renal diseases. Okay, like that. So fourth one is we have to check the hepatic function, renal function, and their interaction with the drugs which are already prescribed. And fifth one is we have to de-prescribe. Okay, by going to this step here. Okay, in med stopper we should go, and what we have to do, we have to enter all the drugs, and we should find if any drug is showing any lethal consequence, and we should de-prescribe, or we can decrease the dose, or alternatively we can go with the other drugs also, whichever it is appropriate. This is the fifth step. And final is follow up, monitor and follow up. So these are the 6 steps we should follow while checking the each patient. Now I'll try to explain you with the practical cases. Remember this 6-step algorithm when you are uh, treating any geriatric patient or when you are following any geriatric patient. First one is we have to list out all the drugs what they are taking, and second one we have to see the goals what they are having, I mean what goals we have, and third one we have to check whether the drugs are given properly or not, like their indication, benefit or harm, or if they are causing anything. Okay, drug interactions, if they are causing any adverse drug effects, if doses are given properly or not, all the things we have to assess. Okay, and fourth we have to check the patient's renal function and kidney function. Okay, and after that we should go with the deprescribing or dose adjustment, and finally we have to monitor the case. So this is the practical 6-step method algorithm we have to perform in the hospitals. Now we have the first case. See, I told all geriatric patients are having polypharmacy. Yes or no? Because geriatric patients are not having single disease, they will be having multiple comorbid disease conditions. Till now whatever you have listened, just keep it away. From now just try to focus here. I'll be practically explaining you the case how to manage the geriatric patients. Okay, see, in the first case, 82 years old female patient who is having hypertension and type 2 diabetes. Along with that, patient is having osteoarthritis and insomnia. Just see, 82 years old female patient is there, having hypertension, having diabetes, having osteoarthritis. 82 years female patients they will have estrogen deficiency. So definitely they will have osteoporosis. Okay. So and patient is also having insomnia. Okay. Night times patient is unable to sleep. And 2 times patient has fallen. So 2 falls last 3 months. In last 3 months, 2 times patient has fallen. That means patient had some what we can say hypotension and blackouts has occurred, and 2 times patient has fallen. So this is the complaint. So patient is having hypertension, diabetes, osteoarthritis and insomnia. Along with that, patient is saying that he is having history of falls. Now patient is taking amlodipine and patient is taking lisinopril, AC inhibitor, amlodipine and lisinopril. These are for hypertension, and patient is taking glimepiride. These may be for diabetes, and diazepam, long acting, may be given for insomnia. And here you see patient is given oxybutynin. Actually, oxybutynin is anticholinergic drug, I think, anticholinergic drug. Okay. And here ibuprofen is given whenever patient is having pain. This may be for osteoarthritis. And some OTC sleep aids also patient is taking. So, okay. So these are the different drugs patient is taking for these many disease conditions. Now, if you see the vitals, patient is having orthostatic drop. That means patient is having hypotension, maybe due to 2 or 3 drugs. Here patient is taking amlodipine and lisinopril. And I don't think 2 drugs are necessary here. If one drug is
The voice is breaking, sir.
wait a second, wait a second. Actually, I'm getting some calls, so my audio is disconnecting. Am I audible now?
Yes.
Yes, sir.
Yes, yes. Am I audible now?
Yes, sir.
Okay, okay, fine. See, I think you all understood the case. See, 82 years female patient is there. Patient is suffering with hypertension, diabetes, and osteoarthritis and insomnia. And patient had complaints of falls, and patient is taking amlodipine, lisinopril, I think you all have gone through this. Okay, I'll not repeat. Patient is taking amlodipine, lisinopril, glimepiride, diazepam, and oxybutynin and ibuprofen. All these patient is taking, and in vitals, if you find that patient is having severe hypotension, BP is decreased here, and creatinine clearance here it is patient's GFR is 45. Okay, that is very low. I mean, 50% of kidneys are not functioning. Actually, if we imagine 90 ml as normal, here patient's GFR is 45. That means 50% of kidneys are functioning. Okay, that you have to remember.
You are not audible, sir. I think sir is having a bit of a network issue. Meanwhile, if you guys have any question, feel free to write them in the chat box. We can have them answer in the Q&A session.
I think I'm audible now.
Yes, sir, you are audible.
Let me share my screen. Wait. I think now my screen is also visible, right?
Yes,
I'm
sir.
getting some multiple calls and it is disconnecting. I'm sorry. Okay. So here, see, in our case, I think you have gone through this case. Okay. This case is very easy. So we will try to solve this case. Patient is a known case of hypertension, diabetes, osteoarthritis, insomnia, and the patient is taking amlodipine, lisinopril, glimepiride, diazepam for maybe for insomnia, and oxybutynin. Okay. Now, if we see the problems for this case, patient is having a main problem is hypotension. Patient is having hypotension. Okay. That is one major problem. Patient is having drug-drug interaction between benzodiazepine and anticholinergic drug. Can anyone tell me what might be the drug interaction between these two drugs? what is the interaction and what is the outcome for these both the drugs? Can anyone tell me? When benzodiazepines are given along with anticholinergic drugs, what output or what adverse effect is seen in patient? I think my voice is clear to everybody. Just try
Yes, sir,
to,
your voice is clear.
yes, yes. Anybody from the class, can anyone tell what is the interaction between benzodiazepine and anticholinergic drug? Just now I told all anticholinergic drugs will cause one adverse effect. What did I tell? Anticholinergic drugs will cause one adverse effect.
Constipation.
Anybody from Parul University? Some students might be giving
Constipation.
answers in the chat. Yes, yes, yes. Very good. Constipation. It will cause
Sir,
constipation and all
constipation.
benzo. Very good. Very good. Very good. Okay. So here you see, patient is having patient will have a risk of constipation. Along with that, patient will have risk of hypotension and fall. Okay, so these are the two problems. And next here you can see NSAID risk is also there, because in geriatric patients, if we take NSAIDs, they may cause nephrotoxicity. Okay, usually all NSAIDs, what they do, they will decrease the prostaglandin synthesis in the uh, what we can say afferent arteriole, and with that it will cause blood vessel constriction, and with that it will decrease the GFR. Already in this patient GFR is less, and here due to NSAID use it will again aggravate the condition. Anyways, so this is another problem, and here patient is having hypoglycemia risk. Okay, why? Because patient is taking glimepiride. So these are the problems. We found that patient is having fall is one problem. Patient is having drug-drug interaction. This is second problem. And here NSAID risk nephrotoxicity is the third problem. And fourth problem, what we found, patient may have hypoglycemia. And patient's history already it is telling कि patient is having twice patient has fallen. Okay, that may be due to hypoglycemia or that may be due to hypotension also. Okay, see for that, what what is the first step we should do? As I was telling you, what we have to do for this case to solve the case. Can anyone tell me what we have to do in this case?
Sir,
I told no
to
in
prevent
6 steps in algorithm to manage. Yes,
prevent that
please.
uh, prevent that ADR, as you said, that benzodiazepines and anticholinergic,
Yes.
uh, to stop them, or
So we have
considering
to stop them.
titration.
Okay, okay. Okay, one of you is telling ki we have to remove or deprescribe benzodiazepine and anticholinergic drug. So if we deprescribe those drugs, patients will be with insomnia only, right? So for that alternative drug, anything we should go?
Sir,
Yes or no?
we can for insomnia, we can go for some life changes in modification in lifestyle, like sleeping more time.
Very good, excellent point. Okay, you are coming in right direction. Very good. Okay, we
And
can
second,
make the lifestyle modification. Good. Okay, then.
second NSAIDs, in for pain reduction we can use other analgesics, other class.
Okay, we have to choose the NSAIDs which are less harmful for the kidneys. Okay, good,
Sir,
good.
avoiding NSAIDs and giving other class of analgesics.
Okay, other class of analgesics. Do we have any analgesic other than
Uh,
NSAIDs which are
Maybe sir, maybe tramadol.
tramadol? Okay, opioids in elder geriatric patients, tramadol
Uh,
is
it,
not a
it
good
also
choice.
cause
Okay.
constipation. It also cause
Okay.
constipation.
Yes, 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 yes. Okay, but here for NSAID is having risk only. So to prevent the risk, we can advise this drug only during pain. Okay, here already in the prescription they have given NSAID is given SOS. Okay, so like that we can go. We will not advise the patient to take regularly 3 times a day. So we can give this alternative. And the next one is patient is having hypoglycemia. For this, what we have to do? We will
Sir,
try
we
to find
can
out
go
the
for
answer.
other alternatives, as some of the drugs can cause hypoglycemia, risk of hypoglycemia. We can consider other, like in this case is sulfonylureas. We can go for metformin.
Yes, yes, very good, very good. We can go with the metformin, or we can go with some other drugs like alpha glucosidase inhibitors, acarbose, voglibose, or some other drugs which are less hypoglycemic. Okay, good. So let's try to find out the answer. I'm very much impressed with your thinking. Okay, good. Now you see here, first step, what we have to do, we have to review the drugs, whatever the drugs patient has taken. First step is we have to check all the drug list. Okay, and here what we have to deprescribe is we have to remove benzodiazepines. Benzodiazepine can be removed, and reduce the anticholinergic burden. Here actually anticholinergic burden can be relieved by giving some alternative drugs. Actually in our case it was given, oxybutynin, right? Oxybutynin is the anticholinergic drug. Apart from oxybutynin, we have some other alternatives for uh, what we can say, for urinary urgency and all those things. Okay, anyways, that we will see. Okay, reduce the anticholinergic burden and then reconsider NSAID. So as you already told, one of you already told, ki NSAID has to be reconsidered, which one is less toxic, that we can go. And here we have to change the glimepiride to safer option like metformin. We have some other oral hypoglycemic drugs which have lesser hypoglycemic effect. Okay, so like this we have to check the patient's prescription here. Now what we will do here, what suggested actions we have is, first one, diazepam dose has to be tapered. Directly we should not remove the drug. Here it was already written, deprescribe the benzodiazepine, right? So diazepam, suddenly if you remove, what will happen? It will show some withdrawal symptoms. So what we should do? We should go with tapering. Okay, slowly we have to decrease the dose and we have to remove that drug. That is one thing. Okay, and we have to plan the non-pharmacological methods like advising the patients, if patient is having habit of taking coffee, tea at night, and if they are having habit of sleeping at daytime, so lifestyle modification changes we have to advise. Okay, and then here a patient was taking oxybutynin, so apart from that we can go with some other drugs like mirabegron. It is one of the drug which is having same anticholinergic action for overactive bladder. Actually we call overactive bladder, overactive.
Sir,
Yes, please.
mirabegron is not anticholinergic. I think so.
It is not anticholinergic, but it is a beta 3 agonist. Okay, beta 3 agonist it is, but it has actions like anticholinergic, and it is useful for overactive bladder. Okay, so here as patient is taking oxybutynin, so apart from this alternative, best alternative what we can go is mirabegron, that can be given. And next we have to try to stop the NSAID and use some topical agents. Okay, here we can go with topical NSAIDs for decreasing the nephrotoxicity or GI related toxicities. We can go with the topical drugs. Okay, and we have to replace the glimepiride with safer agents, or we can decrease the dose. Okay, there are some diabetic patients where sulfonylureas are very effective. Okay, in majority of cases sulfonylurea is the drug of choice. We can't change sulfonylureas. So in that cases what we have to do, If patient is having hypoglycemic symptoms, we have to decrease the dose, or we have to replace some other drugs which are having high protein binding capacity. Actually, sulfonylureas, what they do, they are having high protein binding affinity. Along with sulfonylureas, if any other drug is given which is having high protein binding capacity, so sulfonylurea toxicity can be seen. If such case is there, we have to replace the other drugs which are having high protein binding capacity. That we have to check. Okay, so this is one thing. And last, we have to check the patient's hypotension. If patient is having postural hypotension, and for that, patient is already taking two drugs. One is CCB and one is AC inhibitor. So in that case, we have to uh, deprescribe one drug and we have to continue the other. Like that, we can go. If needed, both the drugs can be given, and we can manage the other symptoms, like if patient is having lifestyle modification, anything that we can go. Now we'll go to the next case. I think this case you already you all understood. Okay. Now next is case 2. I think our time is up. Do we have time? Am I audible? Shall I go with the second case? I think I have another case also. I planned to uh, discuss the aminoglycosides and digoxin in detail. I think, okay, whatever it is, I think we discussed one case. Do you have any questions related to this case? Anybody?
Sir, at least, sir, we can have the review of that next cases, sir, please.
Yes, yes. Okay, okay. If we have time, I'll continue. Shall we? Okay, I'll
Yes,
just
sir.
try to complete this. Yeah, okay. See, here we have 70 years old male patient with CKD whose GFR is 32, and this patient is admitted with urosepsis. Okay, and patient was prescribed with gentamicin 5 mg per kg, which is a standard dose according to the body weight. And here the problem is patient is having risk of accumulation because all aminoglycosides will cause nephrotoxicity and ototoxicity. And for this case, what we have to do, we have to check the patient's GFR and patient's body weight, and we have to calculate the dose, exactly how much dose is required as gentamicin, and that dose is given. Or we can give alternative drugs, like here if gentamicin is given, which is already a potential harmful drug for nephrotoxicity, so here we can go with the safer drugs like penicillins we have, cephalosporins we have to check the what we can say, we have to perform the culture sensitivity test, and we can go the safer antibiotic. Okay, that is the simple step here in case 2. And here in case 3, patient is having heart failure and patient is taking digoxin. So if we go through the case, 78 years old female patient who is having heart failure, atrial fibrillation and chronic kidney disease, and patient is taking 0.25 mg of digoxin daily, and patient is already along with digoxin, patient is taking verapamil, which is a calcium channel blocker, which is a non-dihydropyridine calcium channel blocker. Okay, and here patient is having confusion and nausea. So patient serum potassium is also low. So in this case, what we have to do? In this case, we have some issues like drug interaction we have, which may lead to bradycardia, and patient is having low serum potassium levels and renal impairment. And because of this, patient is having digoxin toxicity. Actually, about digoxin, I should explain in detail. Anyways, so here the risk factor for this digoxin toxicity is low potassium and geriatric age itself. Okay, so because of that, patient had digoxin toxicity, and here what we have to do is we should maintain the potassium levels and restrict the digoxin doses that we can go. And here calcium channel blocker, which is a verapamil, we can change with the other drug. We can go with other options. Okay, so that is about this case. That's it about the session. If you have any queries, feel free. Okay, I don't think we have queries. We can go with the next session. Okay. Actually, I'm sorry, we had a lot of network related issues, and because of certain problems, the session was not that effective. Anyways, thank you for this opportunity for the RX doctors team, particularly all the team members are doing a lot of efforts. Okay. Okay, then thank you everybody. Thank
Thank
you
you, sir.
for
Thank you.
joining the session. Okay. Okay.
Thank you so much, Dr. S.P. Srinivas Nayak, sir, for that insightful and highly practical clinical case discussion on optimizing geriatric pharmacotherapy. Your ability to combine academic depth with real world application has given us all a clear evidence based approach to improving patient safety and outcomes in elderly care. We truly appreciate the time, dedication, and knowledge you have shared today with us, sir. Thank you so much. Okay, so moving ahead to our third session for today, which is led by Dr. S. Manoj Kumar, sir. Dr. S. Manoj Kumar is an accomplished clinical pharmacist and healthcare leader with strong expertise in patient centered pharmaceutical care and medication management. He served as the medical director at Dr. Manoj Medication Opinion Center, where he led initiatives in evidence based medication guidance and patient safety. He has in depth knowledge in medication error detection, patient counseling, adverse drug reaction monitoring, drug interaction checks, and treatment chart reviews, gained through extensive clinical practice at government medical college and hospitals. His professional exposure also include work in specialized areas such as neurology at Glendale Global Hospital and gastroenterology at Prashant Super Speciality Hospital. Dr. Manoj Kumar is a proud alumnus of JSS College of Pharmacy OT, where he built the academic foundation for his successful career in clinical pharmacy. His journey reflects a commitment to improving patient outcomes, ensuring medication safety, and fostering excellence in pharmaceutical practice. So please join me in welcoming Dr. S. Manoj Kumar. Sir, the stage is all yours. Welcome.
Thanks, Ms. Harshri, for your wonderful introduction. Um, Hello, everyone. This is Manoj here, Dr. Manoj Medication Opinion Center, Medical Director. Could you guys hear me?
Yes, sir, you're audible.
Yes, that's grand. And that was a nice session by Dr. Srinivas of optimizing geriatric pharmacotherapy. And he gave some insightful things about those medication and interactions and few case discussions, and that's very much important for us as a pharmacist, clinical pharmacist, as we work with inpatients, right? Yeah. So thanks again for Dr. Srinivas. And now, uh, could you all hear me? Right? Am I audible?
Yes, sir, you're
Yes, sir.
audible.
Okay, and first of all, thank you so much for Dr. From the RX team for inviting me for this conference. Yes, and as you all know that our pharmacist, as a clinical pharmacist, at this present day, it is very difficult for us to get a proper recognition in hospitals and so on. But yet, it's a positive sign that